Hi, everyone. Welcome. We'll just wait about a minute for everyone to join before we begin. Let's go ahead and get started. Welcome to today's webinar. I'm Mandy Sankuler, your Director of Partnerships and Communications, and I am very happy to be here today and welcoming you to this webinar that's going to be on cardiovascular inflammation, targeting tomorrow's risk today. Before we begin with an introduction with Dr. Nimoityn, I'm going to just share a few slides to let you know that all attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition, but we encourage you to take those questions back to your healthcare providers. Please type any of your questions into the Q&A box so that we can answer them at the end of the presentation. And please note that this webinar is being recorded and will be available on our website and on our YouTube channel. We also wanted to take this opportunity to thank AJIFA. With their support, we are able to bring you today's education. And now I would like to introduce today's presenter, Dr. Nimoityn, who's a clinical cardiologist at Cardiology Consultants of Philadelphia at Jefferson. He has a Bachelor of Science degree in biology with distinction from the University of the Sciences and a Doctor of Medicine degree from Sidney Kimmel Medical College at Thomas Jefferson University. His internship was at Drexel University College of Medicine, Hahnemann University Hospital, and his residency in internal medicine and fellowship in cardiovascular disease were at Thomas Jefferson University Hospital. He is a diplomate of the American Board of Internal Medicine and Subspecialty Board of Cardiovascular Disease and is a fellow of the American College of Cardiology. Dr. Nimoityn is a clinical assistant professor of medicine at Sidney Kimmel Medical College at Thomas Jefferson University and an attending physician at Thomas Jefferson University Hospital, where he has held numerous leadership positions, including president of the medical staff, chair of several committees of the medical staff, member of the Hospital Board of Trustees, and was a member of the Executive Committee of the medical staff for 18 years. He's published in the fields of genetic disease, perioperative cardiovascular medicine, lipid disorders, and preventative cardiology. So Dr. Nimoityn, welcome, and thank you for making time for us and our members today. We look forward to your presentation.
Thank you very much, Mandy. It's an honor to be here at your wonderful organization, and I thank all your participants for listening in. I was interested in reading the history of your organization, going back to Dr. Dwight Harkin, who was truly one of the original pioneers of cardiac surgery. I practiced at the hospital where Dr. John Gibbon invented the heart-lung machine and used it for the first time in 1953, but Dr. Harkin was doing heart surgery for many years before that, having left his position at Harvard Medical School to join the U.S. Army. And during World War II was faced with tremendously complex traumatic injuries that involved the heart, and where he had to innovate and do things to try to save soldiers without any background of what could be done, because the things he was doing had never been done before. And if you're interested in the history of this, there's a great book. It's called The Heart Healers. It was published a number of years ago, written by Dr. James Forrester, who was the retired chairman of cardiology at Cedars-Sinai. And he has a whole chapter on Dr. Harkin. And I heard him speak shortly after the book was published. He gave a keynote address at a big cardiovascular meeting. And one of his comments about Dr. Harkin was, he said, he was a man you would never forget. So I thought that was a very interesting sideline. So to start today with cardiovascular inflammation, people think this is a very new field, and actually it's been evolving for quite some time. If you can go to the next slide, please. So to look at the breadth of this problem, coronary artery disease is the leading cause of death in the United States. It's the #1 cause of death, with heart disease resulting in 800,000 heart attacks per year. And 20% of those patients end up having a recurrence. Stroke is the #5 cause of death in the United States. resulting in 795,000, almost as many as the number of heart attacks. And there's a 25% recurrence rate. Arteriosclerotic cardiovascular disease results in 2 million hospitalizations per year and approximately 400,000 deaths. So it's very important that patients with these problems be identified early and be treated appropriately. Next slide. So just to go back to some of the history, a lot of physicians today think that when they hear about vascular inflammation, and we're going to concentrate just on vascular inflammation, not other types of cardiac inflammation, such as inflammation that affects the heart muscle, the valves, or the electrical system, but just the blood vessels. But if you look back, these are slides from 3 different review papers going back to Russell Ross from the University of Washington Medical School, who in 1999 wrote this paper where his opening sentence was atherosclerosis is an inflammatory disease. And then he went on to talk about how people thought that atherosclerosis was just due to deposition of lipids within an artery wall, but that when you looked at what was actually going on, complex mechanisms were going on within the wall of the artery, which involved various types of cells and chemicals. And he said, if you sum that up in an aggregate, it's inflammation. Going on to the next paper here from 2005, Goran Hansen from the Karolinska Institute started to talk about how if you look at what's going on inside the artery wall, you have a multitude of white blood cells and chemicals and chemical mediators. And so a lot was going on inside the wall. It wasn't just a deposition of lipid material. And, you know, it was thought originally that after patients would be treated for their lipids, that coronary artery disease would disappear as a major health problem, but it still continued. And so further research was done. Peter Libby up at Brigham and Women's Hospital in 2004 published this other paper where he showed that there was a complex process going on within the plaque. And you can see there's a plaque here. And within the plaque, you have, you initially have some lipid material which gets into white blood cells. Those white blood cells get transformed into other types of white blood cells called macrophages. They go within the wall. They start to produce inflammatory chemicals called cytokines. They produce chemicals which result in clotting. And so it's a very, very complex process. And it's much more complex than was originally thought back before Dr. Ross was writing, where people thought that it was just a matter of depositing lipid in an artery. And so when you talk to patients, patients very often think that it's like a pipe in a house that just gets crud inside it, and you can just clean out the crud with Drano or something like that. In fact, patients ask that, how can I clean that out? And what has become very, very better understood is that we thought that the problems occurred with coronary artery disease by the artery becoming progressively narrowed until the point where flow was impeded. And then the thought was that a clot just formed from the sluggishness of the flow, and then a heart attack would occur. But actually, what's been found in it's thinned, the cap has inflammatory chemicals. The plaque can either rupture or the surface of the cap can erode. These inflammatory chemicals and chemicals that promote clotting get into the blood, and a clot forms and a heart attack occurs. So over 60% of people that have a heart attack actually have it based on disruption of a plaque in one of their arteries that was not narrowed enough to be limiting flow, not narrowed enough to be showing up on a stress test, and not being enough to produce any symptoms. And so when people hear the shocking story about somebody who was feeling well and suddenly had a heart attack, they have a trouble understanding it. But this is what goes on. One of the commonest examples was Tim Russert, the newscaster who many years ago died of a documented fatal heart attack 2 weeks after having a normal stress test. So we can go on to the next slide. So inflammation became apparent as a significant cause of the process when it became apparent that even after you treated lipids, there was still a lot of residual risk. And this slide shows two graphs. On the right side, this sloping curve down shows that the higher the LDL levels are, the less the survival rate is after a number of years. And if you look at the left side, you see an almost identical graph where if you plot the high sensitivity C-reactive protein, a blood marker of vascular inflammation, you see that the higher the level is, the less survival is over time. So both low-grade systemic inflammation and elevation of LDL cholesterol, both are major factors in the evolution of coronary artery disease. Next slide, please. Could I have the next slide, please?
I did advance the next slide, Dr. Nimoityn.
Oh, I'm sorry.
That's okay. I think we're just
Okay.
getting bad weather and we're freezing a little bit.
Thank you.
No worries.
Okay, so in assessing this residual risk, Dr. Paul Ridker, who was the cardiologist from Brigham and Women's Hospital, who originally developed the high sensitivity C-reactive protein test, and has been a pioneer in this in the concept that arteriosclerosis was an inflammatory process. He's now outlined 3 pillars of residual risk. So on the left side, you have the cholesterol risk, which is mainly related to the LDL cholesterol, the bad cholesterol. And the target for that depends upon the patient's situation, whether they have evidence of coronary artery disease or not. If they do have coronary artery disease, whether they've had a cardiovascular event, such as a heart attack, and especially if they've had recurrent events. And then triglycerides are also a factor as well, which has to be handled based upon the patient's individual situation. The next pillar is the thrombotic risk, and that's the blood clotting risk. And that's influenced by things like smoking and people who have peripheral arterial disease where there's significant problems with clotting. And then on the right side is the residual inflammatory risk. And that is what has been assessed by the high sensitivity C-reactive protein. Next slide. So in trying to probe further into this process, Dr. Ridker planned a trial called the Jupiter trial, which was published in 2008. And I remember when this came out, everybody was sort of surprised at the results, because what he did is he took a large group of individuals who had a normal LDL cholesterol, but had elevated high sensitivity C-reactive protein. So they had low cholesterol, but high inflammatory marker. And he gave them a statin. He gave them 20 milligrams of rosuvastatin. And he showed significantly decreased risk of events. And so that shook everybody up and really was a major advance in understanding that inflammation was a definite problem with vascular disease. Next slide, please. So the next step was that Dr. Ridker ran a trial called the CANTOS trial, which was a landmark trial that was published in 2017. And what he did there was he took an investigational agent. It was called canakinumab. It was a monoclonal antibody against one of the inflammatory markers. It was a marker called interleukin-1 beta. And that particular chemical gets transformed into another chemical, which eventually in the liver becomes this high sensitivity C-reactive protein that he was able to measure. And so what he did was he took patients who had myocardial infarctions, but still had elevation of their high sensitivity C-reactive protein after they were treated for their lipids. And he showed that if he could block this inflammatory pathway, he could significantly decrease risk. However, that product was not practical to produce because of cost and also some side effects. However, it turned out to be useful in another illness that's not cardiovascular. So a search was on for what other drugs might be available that would block this same inflammatory pathway. And colchicine was identified as blocking this same inflammatory pathway. So colchicine is a drug that has actually been around for thousands of years. It comes from a plant called the autumn crocus, and it's been used for a long time for gout, for pericarditis, and for familial Mediterranean fever, conditions that all are based upon the same inflammatory pathway. It was actually brought to the United States by Ben Franklin, who had gout when he was living in France, and they gave him colchicine for that. So if you look at this slide here, what you can see is that the colchicine has a number of effects. Up on the right, you can see those little blue swirls. They're microtubules, which are very small components inside cells, and the colchicine interferes with the assembly of the microtubules. And then down where you see the purple cells, it interferes then with white blood cell function and activation. And then the little things on the side of those purple cells are the platelets, the clotting cells. So it interferes with activation of inflammatory white blood cells that produce inflammatory chemicals. That interferes then with their interaction with platelets, which are clotting cells. And so you remember back to these things being important in the evolution and activation and disruption of plaque, causing a heart attack. This interfered with the risk. And so, so studies began to be planned to try to see if colchicine would work clinically and actually decreasing cardiac events. Next slide, please. So there were 3 major trials that were done with a lower dose form of colchicine than was used in gout. So in gout, typically it was a 0.6 milligram tablet. With cardiovascular risk, the decision was made to use a 0.5 milligram tablet. That may sound like a small difference, but it's a 20% increase from the low dose colchicine to the old form of colchicine. And the reason for this is that colchicine has a what's called a low therapeutic index, which means that if you give too much, it can become toxic. But if you give the right amount, it's safe. And if people have any kind of impairment of their kidney function, the dose that has been designed for gout can build up in your system and can become problematic, whereas the 0.5 milligram at reasonable levels of kidney function is safe. At very, very low levels of kidney function, it can be problematic. So I'm just going to review 2 of the studies. This study was called the LODOCO-2 trial. LODOCO standing for low dose colchicine, and that's actually the name of the product that was approved by the FDA for this purpose. And in this study, what they did was they took people who had cardiovascular risk and gave half of them LODOCO. And this was 5,000 patients who were treated for over 5 years. 94% of the patients were already on statins and were compliant with the statins. And they showed that over the period of the 5 years, there was a 31% reduction in cardiovascular death, heart attack, stroke, and need for coronary revascularization procedures such as coronary bypass surgery or placement of stents. Next slide. And then if you look at the graphs here, if you look primarily at the graph on the right, what you can see is that over the horizontal axis, which is a 5-year period, the difference between the risk of the patients on low-dose colchicine in brown versus the placebo in blue, the curves separated and became very different the further along you went, so that by a 5-year period, the risk reduction was very significant, namely a 31% reduction in cardiovascular events. And the safety profile was found to be very good. There was no increased risk of infections, drop in white blood cells, cancer, or muscle-related problems. And there was an infrequent and short-term risk of some gastrointestinal side effects, which usually subsided. Next trial. The other trial I just like to go over is called the COLCOT trial. And in that study, they took patients who had a myocardial infarction within the prior 30 days. Half of the patients were given low-dose colchicine, and the other half were given placebo, and they showed a 23% reduction in risk. Next slide, please. Now, when new therapies emerge, they, if they have enough support in terms of number of studies, quality of studies, and so forth, the goal is to get those new treatments into the guidelines. And it's a very difficult process getting guideline committees to take on new therapies and new ideas. But I'm going to show you two here, and I want to, after I show you this slide, I'm going to show you how things have even evolved within the last couple of years. And in the slide on the right, the 2021 European Society Cardiology Guidelines on Cardiovascular Disease Prevention said low-dose colchicine, 0.5 milligrams daily, may be considered in secondary prevention. Secondary prevention means in patients who already have a diagnosis of coronary artery disease, particularly if other factors are insufficiently controlled or if recurrent cardiovascular disease events occur under optimal therapy. And then in the 2023 guidelines, and I should mention the low-dose colchicine was approved by the FDA in June of 2023. So the European guidelines even recommended consideration of it before it was even approved in the United States. And then the 2023 guidelines, which were endorsed by the American Heart Association, American College of Cardiology, American College of Chest Physicians, American Society of Preventive Cardiology, National Lipid Association, and Preventive Cardiac Nursing Association, said in patients with chronic cardiovascular disease, the addition of colchicine for secondary prevention may be considered to reduce recurrent hsCVD events. And then next slide. And then just over Labor Day weekend, which is when the European Society for Cardiology meets annually with new guidelines, they upgraded their recommendation on colchicine to what's called a class 2A recommendation with level of evidence A. That means it has a high level of evidence. And the recommendation was that in chronic coronary syndrome patients with atherosclerotic coronary artery disease, low-dose colchicine, specifically 0.5 milligrams daily, should be considered to reduce myocardial infarction, stroke, and the need for coronary revascularization. And next slide, please. Now, if you look at how much risk is reduced with the low-dose colchicine, on this slide, you can see a number of other drugs that can be added after the patient's LDL cholesterol is treated with high-dose statins. On the very left, you see the Improve It trial, which used a drug called ezetimibe or Zetia, which is usually the next drug added to a statin when LDL needs to be lowered further. And that drug usually lowers the LDL by about 20%, but it depends on genetics. And that resulted in a 6% additional risk reduction over that of the statin alone. The next three trials, the Fourier trial, the Spire-2 trial, and the Odyssey trial, were the injectable PCSK9 drugs, which are Repatha and Praluent. These are drugs that come in a little pen injector, and every 2 weeks, the patient just pushes a button and injects. And these are monoclonal antibodies against the LDL receptor, and they've been a major advance. But if you look at the risk reduction, it's an additional 15% reduction. They do lower LDL by an additional 60%, but the risk reduction is about 15%. The next study to the right of that is the CANTOS trial, and that's the trial that Dr. Richter reported in 2017 with this investigational agent, which also resulted in about a 15% risk reduction. The next in orange is the COLCOT trial. That's the one that showed that in patients who were started on low-dose colchicine, 0.5 milligrams a day, within 30 days of a heart attack, had a 23% risk reduction. And in the LODOCO-2 trial, the 5,000 patients treated for 5 years with colchicine 0.5 milligrams daily, who had either cardiovascular disease or multiple risk factors, 31% reduction in cardiovascular death, heart attack, stroke, and need for coronary revascularization. So the risk reduction is twice that of the injectable cholesterol drugs. Not to minimize that, because you're not trying to compete, but you're trying to add additional risk reduction. So if you add a 31% risk reduction to an already 15% risk reduction plus the risk reduction from the statin, you can have substantial reduction of future cardiovascular risk. Next slide, please. So in looking at the value of high sensitivity C-reactive protein, the timing of that is important. It's important to do it when somebody's in a relatively steady state, not in the midst of any kind of acute inflammatory process or infection or anything like that, and should be checked as part of initial screening. In fact, the Wall Street Journal had an article just within the last month saying that for patients who are going to their doctor to ask about cardiovascular risk, they should be asking for other studies, including lipoprotein(a), which we'll mention later, and things like that. The second is that other therapies may result in lower hsCVD risk, including some of the diabetes medications and obesity treatments. Those, of course, are getting a lot of attention, including the GLP-1 agonists. You've heard of those, the Ozempic and Wegovy and Mounjaro and Zepbound. Now, the next is treating obesity with weight loss reduction. They also decrease systemic inflammation. Next slide, please. So as far as how colchicine is metabolized, it's absorbed in the ileum and the jejunum, that's the small intestine. It's metabolized by the liver. It's excreted about 60 to 80% in the bile, and it's excreted out into the kidneys. 20 to 40% is excreted by the kidneys. Therefore, people who have significant chronic liver disease or chronic kidney disease are not good candidates. And as you can also see on this slide on the left, it does go into breast milk and crosses the placenta, so it's contraindicated in women who are either pregnant or nursing. Next slide, please. Now, I think it's important to compare the dosing of colchicine between the traditional 0.6 milligram, which has been used for gout, pericarditis, and familial Mediterranean fever, and the 0.5 milligram low-dose colchicine, which has now been approved for cardiovascular risk reduction. The 0.6 milligram was used in high dose for short term for people with acute gout, acute pericarditis, people who needed immediate relief, and then it would be usually discontinued. The 0.5 milligram low dose is indicated to reduce cardiovascular events and is the only product that has been approved for cardiovascular risk reduction. It's used for very long term at low doses, and the goal is to prevent what is called MACE, major adverse cardiac events, with an acceptable safety window. And these differences, which are important in all patients, are even more important in patients who are over 65 years of age. And this is something that I think is very important to focus on, because I've gotten calls from pharmacies saying, I wrote a prescription for low-dose colchicine, and the pharmacy said, well, the patient should get the 0.6 because it's cheaper, but the 0.6 is not safe for those patients long-term and has not been proven to be effective, and it's not approved for that purpose. So that's an important distinction. Next slide, please. Just a couple other things about colchicine metabolism and drug-drug interactions. Colchicine is metabolized in the liver through a certain pathway. It's called the CYP3A4 pathway. And so certain other drugs which can be also metabolized by that pathway can be problematic. For instance, Paxlovid, which is the drug that's the commonest drug used for COVID-19, can be a problem, and you have to use a different drug for COVID-19. And then there are some other drugs that are called P-glycoprotein inhibitors. There's not a lot of those. There's a couple of antibiotics and antifungal drugs. So it's necessary to know what other drugs patients are on when colchicine or any other complicated drug is prescribed for them. Next slide. Now, in the studies that have been done, it's also been safe to take low-dose colchicine, the 0.5 milligram colchicine, with statins, as shown in the COLCOT trial and the LODOCO-2 trial. And these included patients who were heavily treated with statins. So these patients were mostly treated with high-dose statins. They were given low-dose colchicine, and it was shown to be safe. Because there's a theoretical concern, pharmacies will often call the physician and say, you prescribed low-dose colchicine, you should know there's a drug-drug interaction between statins and colchicine, and this is known, it's not clinically significant. Most of the patients, as I mentioned in these two studies that went on low-dose colchicine, were also on high-dose statins, and it was not a problem. And these trials also showed that it was safe to take aspirin with no increased bleeding risk. And most of these patients having cardiovascular disease or risk were also on aspirin as well. Next slide. So the take-home messages are beyond diet, exercise, and smoking cessation. Lipid lowering remains our most important pharmacologic intervention to reduce atherosclerotic events. After statin therapy, residual inflammatory risk, as assessed by the high-sensitivity C-reactive protein test, is very common and is at least as important as residual cholesterol risk, as assessed by LDL cholesterol. So you're not competing, you're trying to reduce the risk of the lipid issue and reducing the risk of the residual inflammatory risk. So evaluating high sensitivity C-reactive protein as well as LDL should be considered as a routine part of care for our patients. And low-dose colchicine is used in the landmark LODOCO 2 trial and COLCOT randomized trials, provides a simple and safe method to significantly lower cardiovascular risk when given on top of statin therapy. Next slide.
Do you see it? It's been advanced.
So there's a couple more take-home messages when we get to the next slide. Number 5, low-dose colchicine should be avoided in patients with significant renal or hepatic disease, that's renal or kidney or liver, and temporarily discontinued when there is concomitant use of certain other agents. These 3 that are listed here: clarithromycin, which is an antibiotic, ketoconazole, and fluconazole, which are antifungal drugs. When patients are on those that are low-dose colchicine, should be temporarily stopped. And residual inflammatory risk and residual cholesterol risk, as I mentioned, are not in competition, but are synergistic to decrease risk maximally. And evidence supports the fundamental prevention efforts directed at diet, weight loss, exercise, and smoking cessation, all of which lower vascular inflammation and lower cardiovascular event rates. Next slide. Now, this is very new. This article just was published August 31st, called Inflammation, Cholesterol, Lipoprotein a, and 30-year cardiovascular outcomes in women. This study was also co-authored, the lead author was Paul Ridker from Brigham and Women's Hospital. And what Dr. Ridker did was he ran a trial where they took a huge number of women who were healthy, measured these parameters, and then followed them for 30 years to see what happened. Now, lipoprotein, so inflammation was measured with high sensitivity C-reactive protein. Cholesterol was measured, with the LDL cholesterol and other lipid parameters. And lipoprotein a is a genetically determined lipid fraction that is not that uncommon and is primarily genetically determined. So it's something you just need to check once and then you don't have to repeat it. And it's been associated with a significantly increased risk of premature coronary artery disease, which means coronary artery disease developing at a young age, stroke, and aortic stenosis, which is a narrowed valve, the main valve that leads out of the heart to the body. And so what they found in this trial, and this was published in the New England Journal of Medicine just within the last month, a single combined measure of high sensitivity CRP, LDL cholesterol, and lipoprotein a levels among initially healthy US women were predictive of incident cardiovascular events during a 30-year period. These data support efforts to extend strategies for the primary prevention of atherosclerotic events beyond traditional 10-year estimates of risk. And this is very important because for so many years, when individuals would come into a cardiologist to get screened for cardiovascular risk, either because a relative or a friend had a cardiovascular event, one of the things that was done was to do a 10-year risk assessment. There were a variety of these calculators that were developed over the years. There was one from the Framingham study of many years ago, which studied 5,000 people in Framingham, Massachusetts for many years. There were American College of Cardiology and American Heart Association calculators. And the problem is, if you have a relatively young person, it doesn't really help them to assess their 10-year risk. You want to know what their lifetime risk is. And because of the way the calculator is generated, one of the biggest drivers of the calculation is the patient's age. So you get a 40-year-old person comes in and says, I want to know what my risk is. And you do the calculation based on their lipids and whether they have high blood pressure and things like that. And then you tell them that they have a low 10-year risk and they do not need a statin. And the person may walk out and say, that's great, I'm done, I never have to be screened again. And so this study validated the fact that we should not just be using 10-year risk assessments, but we have to look beyond a 10-year risk assessment so that we can find people at risk before they develop disease and try to prevent disease rather than just reacting to disease. Next slide, please. So this is a complex slide, but if you just look at the bottom panel, what they showed was that if you looked at these three different markers, high sensitivity C-reactive protein, LDL cholesterol, and lipoprotein little a, they all correlated with an increased cumulative risk of first major cardiac events, including coronary heart disease and stroke. And if you put all three of those together, hsCRP, LDL cholesterol, and lipoprotein A, you see the line at the top, the orange line, you get a very, very strong correlation. So if those people were identified back 30 years ago, and the same data probably applies pretty much to men, but that study hasn't been done yet, you have a very strong validation of being aggressive about reducing lipid risk and reducing residual inflammatory risk before you get the development of coronary artery disease, cardiovascular events, and cardiovascular death. Next slide, please. And therefore, appropriately, when Dr. Ridker published this paper in the New England Journal of Medicine, August 31st, the journal had an accompanying editorial written by Roger Blumenthal from Johns Hopkins titled Prevention of Cardiovascular Disease, Don't Stop Thinking About Tomorrow. And Dr. Blumenthal and Dr. Martin, his associate, wrote, a long-term view can enable earlier recognition of cardiovascular disease risk in women and proactive preventive efforts to mitigate risk. The best way to avoid cardiovascular disease in the future is to reduce risk factors today, because tomorrow will soon be here. Thank you very much, and I hope you enjoyed the presentation.
Thank you, Dr. Nimoityn. That was excellent. I'm going to go ahead and stop share now so that we can take any questions the audience might have. I had a couple while we wait for I know that they're going to have some, but I have a couple just listening. What are the access issues like for this therapy in terms of both doctors being aware of it and offering it to patients, the test, and also to access to insurance covering it? I know with like PCSK9 inhibitors, not everyone has access to that. What's the situation with this?
Well, Mandy, I think you hit on the all the major obstacles. By the way, I just want to mention before I answer, there is a website called cvdinflammation.com that you can get a lot more information on these issues. CVD, cardiovascular disease, cvdinflammation.com. It's a very, very good website, and I think your members would find it very useful. So you've hit on all the problems. So the first is has been identified as therapeutic inertia. And that's sort of defined as the disconnect between what is known and what is available versus what physicians are actually doing. Most non-cardiologists are totally unaware of this, and a significant percentage of cardiologists are also not aware of it because the availability of a treatment for cardiovascular inflammation is relatively new. The drug has only been approved in June of 2023. It became available in the United States in August of 2023. And it has not been promoted enough. And that's why what you're doing today is very, very useful, because very often when new therapies emerge, it takes an informed patient going to his physician and saying, why haven't you given me this? And then if the physician's, cooperative, he goes and looks it up and then starts prescribing for his patients, and he feels that that's appropriate. So most cardiologists have not started doing this. I've talked to some cardiologists who they just say, no, I haven't done it, and they don't really give me a specific reason why. Many patients will say, I feel good. I think I'm fine. I think I'll pass on that for now. As far as the insurance coverage, I know that the manufacturer of the drug is trying to get as much in the way of insurance approvals as possible, because if the insurance companies don't approve it, pharmacies and pharmacy benefit managers can charge whatever they want, and sometimes they just pick a huge number out of the hat. And some of the insurance companies are having a hard time understanding what this is all about. So a lot of times when you get the prior authorization, I should mention also, most of the pharmacies have not started carrying it. The easiest way to get the drug is to send in an electronic prescription to an online pharmacy called BlinkRx. It's BLINK-RX. They're located in, I can never remember if it's Idaho or Iowa, but it's one of the two. And they've actually agreed to cap the price at $99 for a month's supply, with the exception of a couple federal insurances that won't permit them to do that. But I get these prior authorizations back, and some of them will say, the insurance company denied it, saying you haven't tried a cheaper alternative. There's no cheaper alternative. There's no other approved product. The product information that was approved by the FDA is that this is approved to reduce the risk of cardiovascular death, heart attack, stroke, and need for coronary revascularization procedures in adults with either established atherosclerotic cardiovascular disease or multiple risk factors for coronary artery disease. And as Dr. Ridker has commented in some of his presentations, if you look at the wording of the approval for low-dose colchicine, it's almost word for word the approval for statins. And then I've had patients who have even had prior authorizations denied, saying that we haven't tried another drug, which is a cholesterol drug and hasn't even been approved for this purpose. So it's just important for the cardiologist or whoever is prescribing the drug to be able to respond appropriately and say, this is the only drug approved for this purpose. And hopefully, as time goes on, more and more insurance companies will cover it. But it's not exorbitantly expensive for considering the value that it provides.
It seems like there's a lot of work to be done, even like in the advocacy space and policy space, to get insurance companies and clinicians to recognize the importance of it. Absolutely.
But if you go to the big meetings, there's a buzz going on about it. There's a lot of interest, in people that are trying to do cutting edge work.
Yeah. Well, we do have a couple of questions. How much of a bearing does food or nutrition have on developing our atherosclerosis?
So I think it has a significant effect, and none of this talk about fancy drugs is meant to in any way de-emphasize the importance of those things. And those are things that ideally should be started at a young age, even before these other processes begin and before consideration of all these other tests and drugs that we talked about. Having a heart healthy diet, such as the Mediterranean diet, they've shown that the risk of heart attack is tenfold higher in the typical American diet than it is in the typical Mediterranean diet, which includes, fish, fruits, vegetables, extra virgin olive oil, some bread, and a small amount of lean meats, as opposed to the American diet. But so that would decrease the risk of cholesterol levels being elevated, decrease the risk of hypertension if there's not excessive sodium intake, and so forth. But also there are other factors as well. There's an increasing interest now in the gut microbiome, which is the gut microbiome is the population of bacteria and other organisms that live in your gut, and there are estimated 10 trillion organisms in your gut. And 10% of the metabolites, 10% of the chemicals that your body produces are manufactured by the gut microbiome. And what bacteria are prevalent has a lot to do with what you eat. So if you have a diet that's high in beef, for instance, you will foster development of bacteria that release inflammatory metabolites. So when you look at the effect of inflammation, it sort of validates that old expression that you are what you eat.
Yeah, that's fascinating. I know you mentioned this during your presentation, and if we could put it in the chat, if you could spell it out for us, what's the test that's going to see if there's elevated levels of inflammation that people can ask their doctor for? What was that name?
That's a good question, because it's often misinterpreted by the laboratory. It can either be high sensitivity, and then capital C, capital R, capital P, C-reactive protein, or HS, small h, small s, capital C, capital R, capital P, I'm sorry.
Capital P.
So hsCRP, or some of the laboratories use cardio, C-A-R-D-I-O, CRP. And I've been frustrated because I would say about 25% of the high sensitivity C-reactive proteins that I order, which are ordered on forms that also have the exact CPT procedure code, the official procedure code used across the country, when the patients go to LabCorp, Quest, or other hospitals, about 25% of them come back as a plain CRP. The plain CRP, C-reactive protein, was a very old test. There was a non-specific marker for inflammatory states. It's sort of like a test called the sedimentation rate. If the CRP is high, somebody was likely to have some kind of inflammation or infection. And then Dr. Ridker was able to develop this specific high sensitivity C-reactive protein, which is the marker for vascular inflammation. Now, the average risk range on this is said to be 1 to 3, although above 2 is concerning. Below 1 is considered to be low risk, and above 3 is high risk. If the number gets up to around 10, it usually implies non-cardiovascular inflammation and should be repeated at some point in the near future to see if it's coming down.
Okay. So, and I assume these 25% that the tests are being done incorrectly, or it's the wrong test. It's not because they can't test, there's just confusion on the testing location site about what test this is for.
Exactly. Exactly. It's confusion. We've called in the LabCorp rep 2 or 3 times already, and it's such a big bureaucracy, and they have so many different places that are drawing blood that I don't think they can control it. So what I do is when our laboratory studies come in, they're posted right on our electronic medical record on the computer, and I review every one of them as soon as they come in. And if I see the wrong one was done, I just send a note over to one of the medical assistants asking them to call the laboratory and add that on, because the labs typically keep the blood specimen for 7 days, and both of the types of CRP are done on the same type of tube, so they'll usually add that on. But it's It's just annoying when the patient comes in the day after their blood's drawn to find out how their hsCRP is, and you have to tell them that their lab did the wrong study.
Wow, it's so important. You can see how important it is to have like a knowledgeable clinician and also the patient who's willing to continue to advocate for themselves and what testing they should be having and what they have a right to know, even when there's this kind of confusion that can happen on the back end, I think.
Well, I think that's why one of the reasons your organization is so helpful to your members, because of the advocacy as well as the education component.
Yeah. Thank you. Paul is asking, is it necessary to take a statin every day or can you alternate days?
Statins are typically given every day. I know there are some people who take twice the dose every other day, but you know, the way that it's recommended and the way it's approved by the FDA is to take it on a daily basis, unless there are some people who can't tolerate the drug every day and that they're taking a very low dose, less than every day. But if you look at the dosing of statins, the data shows a benefit that can be attributed as much to the intensity of the dose as it can to the level of the blood test. And that's why the guidelines recommend that when you're starting somebody on a statin for the appropriate indications, either in primary prevention, somebody who doesn't have a diagnosis of coronary disease, or in secondary prevention, you should start with a moderate to high intensity statin and then go from there.
I've got a lot of questions in the chat. My mouse seems to have frozen a bit. So we've got the question, what is a recommended LDL level after a heart attack? And what are other tests or labs that can be done to see if there are other arteries that are being clogged up? Although you said we're not supposed to think of it as a drain anymore that's being clogged. It's a lot more intricate than that.
Right. So the LDL that is approved for people who have established cardiovascular disease was lowered a couple of years ago. And the current recommendation from the American College of Cardiology, American Heart Association, is that the LDL should be lowered at least 50% from baseline and should be targeted to less than 55. Now, if you look at, there have been rigorous statistical analyses of all the long-term cholesterol studies, and they've shown that if you have established coronary artery disease, no matter where your LDL starts, very, very high, moderately high, or mildly high, you continue to get additional outcomes benefit no matter how low you lower the LDL, almost down to next to nothing. And with some of the newer drugs, including the PCSK9 inhibitors like the Repatha and the Praluent, you can get very, very low. Now, some of the laboratories, when it goes below 40, will only report less than 40 because the quantitation becomes less accurate at very low levels. Some will report an actual number. So I've seen reports with LDLs down in the single digits occasionally.
Aaron asks, he asked, what is MPO? And then he answered, MPO is a blood test similar to CRP. I don't know if there's a question in there. Maybe you can interpret that better than I can.
NPO or MPO?
M as in Mary.
Myeloperoxidase. You know, I think, you know, there's a whole panel of these things that you can get if you go to different laboratories where they'll give you this whole panel of things. And, you know, there's no real proof that doing these things is going to result in any long-term benefit. I think if you focus on the lipids and you focus on the inflammatory risk, you can really reduce risk significantly. I mean, I think it's amazing how much we've been able to reduce risk, and it'll be interesting to see going forward whether the morbidity and mortality will go down much further than it has already, but it certainly looks like it will be. Now, there are a couple other blood tests that people can do. There's a blood test called ApoB. This is one of the ones that was listed in the Wall Street Journal article, and that basically gives you an assessment of all the atherogenic particles, the LDL, and some of the others that are in with the triglycerides and so forth. In the old days, there was a test that was commonly used called the Liposcience NMR profile, where they would break down your cholesterol into more different subfractions, measure the number of LDL particles and so forth. It became harder, I think one of the problems was it was harder for that data to enter an electronic medical record, and so it's not as commonly used. But the ApoB gives you most of that information. So I think getting the standard lipid panel, the ApoB, the lipoprotein little a one time, and the high sensitivity C-reactive protein, for the most part, will give you what you need to assess risk. And then if you want to go beyond that, the next step would be, assuming the person is not under 30 and more commonly even a little older, the CT cardiac calcium scoring test. This is a CAT scan. It's a very limited CAT scan with very little radiation, about 1/10 the radiation of a nuclear stress test, where you scan for calcium in the coronary arteries. If you have calcium, it means you're developing plaque. It gives you a score. It gives you a percentile score telling you where you fit compared to a matched group of people. And then you can get a future risk score. And then there's a calculation where you can take if you're into the 10-year risk calculators, you can modify the 10-year risk calculator with the calcium score and get even a better scoring system. But I think, I think the direction is going further is going to be more like what was seen in the study that Dr. Richter just published a month ago, looking at baseline studies and being able to predict long-term risk.
Mm-hmm. Is colchicine, is it advisable to take it even if you haven't been diagnosed with hsCVD, but you've got a lot of risk factors? Is there any basis for testing for it and seeing if?
Well, it is approved if you have either established cardiovascular disease or multiple risk factors. The question always becomes, what constitutes multiple risk factors? So it could be a multitude of things that a physician may decide constitute that. It could be hypercholesterolemia, hypertension, diabetes. It could include also having an elevated lipoprotein A. Lipoprotein A, if you look at the factors that increase risk, lipoprotein A is a very powerful factor. Lipoprotein A occurs and is elevated in 20% of the Caucasian population in the United States, and most people have not been screened for it. Because there are some new emerging therapies that may be out within the next couple of years, it's getting a lot of attention now. When I was at the American College of Cardiology annual meeting in Atlanta in March, there was a whole line of cardiologists there getting tested. I was wondering, why haven't these people been tested before? But that's another very worthwhile test.
And someone does mention familiar hypercholesterolemia in the chat as well. And, if you could clarify, if you have Lp(a) raised levels, or you've got familiar hypercholesterolemia, will this therapy then help with those two conditions?
So familial hypercholesterolemia, is a genetic condition. The total cholesterol is usually about 300. The LDL is usually about 200. Those people have to understand that they should have a healthy diet and exercise and lifestyle and all that if their doctor deems that they're safe to exercise. But those things are not going to get their LDL down more than about 10%. And statins aren't likely to do it either. So they need statins, and then they need PCSK9 inhibitors, or there's another drug that's an infusion that can be used. But those people, usually would be considered at high risk, but they can also get a CT cardiac calcium scoring test if they want to pursue it further. But each of those has to be decided on an individual basis by their cardiologist. Okay,
thank you. How have we have got 1 minute left. Geez, this is flying by. I know there were a couple more questions. I don't know. What are your thoughts on taking vitamin K2 to prevent calcification?
I don't think there's any real data on that. There was a study done years ago where they looked at cardiovascular patients, and half of them were given a multivitamin and half were not, and they could not show any benefit at that time. And there's a lot of controversy about nutritional supplements, but I don't think there's any reason to recommend that. Okay,
thank you. And I think we've got time for one more. Can your existing stent in LAD malfunction and cause another heart attack? I don't know if that's really in your purview to answer. It's not. I'm not sure if that's something you're comfortable answering or not.
What is the question?
Says, can your existing stent in LAD and then maybe cause malfunction and can cause another heart attack? I think maybe is what it's supposed to say.
So if a stent is deployed, there's two types of stents. There's the older bare metal stents, which are not commonly used now. They're the new drug-eluting stents, which have been around since 2003, and they release a drug for a period of time, which decreases the likelihood of a process called in-stent restenosis, which is a problem that where the artery narrows at the junction of the stent and the artery. And with the older type of stents, it would occur 15 to 20% in the first 6 months, usually in the second 3 months. With the newer ones, it's probably less than 5%. And so, that can happen when they stay open for the 6 months. Usually they stay open longer than that. So the question always is, when somebody has a recurrent problem, who has a stent, was it in-stent restenosis or was it progressive atherosclerosis?
Thank you. Well, we are a minute over time because this has been such a great conversation. I didn't even get to all the questions, but it just goes to show how needed this information is, and our community is grateful to have you on. So thank you very much.
No, well, thank you for having me. I really enjoyed it.
Thank you. And to everyone who joined, we appreciate you being on, and we will see you soon. Everyone have a good evening and stay safe and dry out there if you're in the Southeast. Bye-bye.
Thank you.